morning all. So today's topic will be on two different topics. One is tinnitus and one is vertigo. Tinnitus and vertigo. So these can be a short essays. You can get for these 4 or 5 more questions. 4 more questions. So first we'll go read about tinnitus. So what is this tinnitus? So as you all know, in otology in ear, the main symptoms the patient can get are hard of hearing, which is difficulty in hearing. The second one is ear discharge. Okay, and the third one could be a pain, that is called ear pain, it's called otalgia. And the main other two symptoms are tinnitus and vertigo. So what does this tinnitus mean, and what is this vertigo? These two we will discuss today. Okay, so tinnitus, the definition being, tinnitus is ringing sensation in the ear or a sound or noise in the ear. Okay, so this sensation of sound or noise will be coming inside from the ear. Okay, actually the sound, what is the normal sound or normal noise? It is all which occurs in the external environment, okay, which is perceived by your ear, whereas this tinnitus is a sound which is created or which is developing in your ear. Okay, so tinnitus is a ringing sensation or sound or noise in the ear. The characteristic feature is that the origin of the sound is within the patient, okay, not from the external environment. It is within the patient, and usually it is unilateral. Okay, which ear is affected, in that ear this tinnitus can occur. And of course, if the patient is having problem in both the ears, it can develop in both the ears, sometimes bilateral. So it may vary in pitch and loudness, and has been variously described by the patient as roaring type, hissing type, swishing type, whistling type, or clicking type of noise. Okay, so whatever the patient comes to you and whatever he says to you, the patient doesn't see this word tinnitus is a medical term. The patient will not tell that when he is coming to the operation theatre or when he is coming for the outpatient department. He will not tell that he is having some tinnitus. Okay, so tinnitus is a medical term, but the patient will describe this tinnitus as getting some roaring sound in the ear, or hissing type, or swishing, rustling, or clicking type. These are the terminologies which the patient will explain when he comes to the OPD, and that you will describe in medical terms as tinnitus. Okay, and tinnitus is more annoying in quiet surroundings, particularly at night, when the masking effect of ambient noise from the environment is lost. So what happens? This tinnitus is more disturbing or annoying in quiet surroundings. So as you all know, this tinnitus is developed within the ear, within the patient. So when the external environment is making some sort of noise or sounds, that sound or noise which is developed by the environment will mask the tinnitus effect which is being developed in the ear. Okay, so this tinnitus is more annoying in quiet surroundings, particularly at night. At night, as you all know, there will be no disturbance, environment will be very calm. At that time, this tinnitus will be more. And this tinnitus is of two types. Okay, there are two types of tinnitus. One is subjective tinnitus and one is the objective tinnitus. So what is this subjective tinnitus? Subjective tinnitus is the ringing sensation in the sound which can be heard only by the patient. Subject means here the subject is a patient. So only the patient can hear this sound. Example like disorders in external ear, middle ear, or inner ear, or eighth nerve, or central nervous system. So any problem in the ear, okay, ear of the patient, like as you all know, all the parts of the ear, the external ear, the middle ear, and the inner ear, and the 8th vestibulocochlear nerve, and the central nervous system. If the patient is having any disorder in these parts, then he can develop this subjective tinnitus. Okay, like examples like disorders in external ear is wax or any foreign body. If the patient is having any wax in the ear, external auditory canal, or any foreign bodies in the ear, or any fluid in the middle ear, okay, that in such type of patients, that tinnitus is called subjective tinnitus, and the second one is objective tinnitus. Okay, and what is this objective tinnitus? It is a tinnitus, it is a ringing sensation in the ear which can even be heard by the examiner with the use of stethoscope, with or without the use of stethoscope. So when you go near to the patient, even you also can, when who is examining the patient, whether the doctor or the physician, whoever may be, when he goes nearby the ear of the patient, even the patient, the examiner also can hear this sound. So this is called objective sound. Okay, and some examples for this objective tinnitus. So objective tinnitus is more in frequency because it is heard even by the opposite person who is examining the patient. So examples being vascular lesions like glomus tumor. So glomus tumor is the tumor of the middle ear of the temporal bone, like, okay, and carotid artery aneurysms. As you all know, in the anterior aspect of your ear there is this carotid artery, and if there is any aneurysm in this carotid artery, the patient can have objective tinnitus. And palatal myoclonus, when the patient is having some disorders of this palatal muscles, then while deglutition or while yawning or swallowing, the patient can feel this tinnitus. The examiner also can feel this tinnitus along with the patient. Okay, so these are the three examples of objective tinnitus which are very important for your MCQs, multiple choice questions you can get while in your PG entrance exams and all. So what are the examples for objective tinnitus? Glomus tumor, carotid artery aneurysms, and palatal myoclonus. And sometimes this tinnitus can also be psychogenic, and they will know if you even how far you, even if you go to try to evaluate the cause, you may not find any cause. The ear will be normal and the central nervous system will be normal, okay, but the patient will be having some tinnitus. So that is called psychogenic tinnitus. Okay, so these are the three types of tinnitus: subjective tinnitus, objective tinnitus, and psychogenic tinnitus. So this is a table. Okay, so etiology of tinnitus. When you get this question, you need to, what are the etiology of tinnitus? This table is taken from your textbook Dhingra. Okay, your standard textbook which you read for your exams. So these are the causes of tinnitus. So there are causes, subjective causes and objective causes. So if we go fast, if you just go read all this. In otology, impacted wax fluid in the middle ear, acute otitis media, chronic otitis media, Meniere's disease, presbyacusis, noise-induced hearing loss, idiopathic sudden sensory neural hearing loss, acoustic neuroma. These are the otological causes for tinnitus. And metabolic causes like hypothyroidism, obesity, hyperlipidemia, vitamin deficiency, mostly vitamin B12 deficiency. And neurological causes for subjective tinnitus are head injury. After a head injury, when there is a labyrinthine concussion, there can be tinnitus. Temporal bone fractures, whiplash injury, multiple sclerosis, post-meningitis, brain hemorrhage and brain infarcts. These are the neurological causes of subjective tinnitus. And cardiovascular causes being hypertension, hypotension, anemia, cardiac arrhythmias, atherosclerosis. Okay, and these are the cardiovascular causes of tinnitus. And pharmacological, it can be due to a few otological drugs, which if the patient is having any ear problem and if he is constantly or frequently using any ear drops, that can cause tinnitus. And ototoxic drugs, these can cause subjective tinnitus. And these psychogenic, like anxiety and depression patients can also feel this tinnitus in the ear. So these are all the subjective causes for subjective tinnitus. And these are the objective tinnitus that even the examiner can feel the tinnitus, okay, can hear the tinnitus, and mainly being vascular aneurysms and other vascular etiologies like arteriovenous shunts, congenital AV, arteriovenous malformations, glomus tumors of middle ear, and arterial broom, carotid aneurysms as we discussed, carotid stenosis, vascular loop pressing on the 8th nerve in internal auditory canal, high riding carotid artery, persistent stapedial artery, and venous hump. Okay, and high descendant jugular bulb. All these are the vascular causes for objective tinnitus. And other causes being parculus, eustachian tube, palatal myoclonus, idiopathic stapedial or tensor tympani myoclonus, dental origin disorders, and clicking of the TM joint. Okay, these are all the causes for objective tinnitus. You need to write this table when they ask for etiology of tinnitus. So we have learned what is tinnitus, what are the types of tinnitus, what is the etiology of tinnitus. And here next the final thing is treatment. So when this patient is having this ringing sensation in the ear, how do you treat? What do you want to do? The first one is the reassurance and psychotherapy. So as you all know, most of the tinnitus cases will not have any cause. Okay, you can't find out where the cause is. Even if you try to do many investigations like some Putin audiometry or impedance audiometry, or even if you do some CT scan or MRI scan, still you don't find the cause of the tinnitus. In such patient, reassurance and psychotherapy should be done. Reassurance is nothing. This is nothing but many times the patient has to learn to live with tinnitus. As you have to explain the patient that there is no particular treatment for your tinnitus and you need to live with it. So that is the psychological counseling, treatment, reassurance, and the techniques of relaxation and biofeedback. And sometimes the sedation, and in some patients which where you can treat the tinnitus, that patients you can may be needed, and this treatment may be needed in initial stages till patient has adjusted to the symptom. And the other one may be the masking of tinnitus. Tinnitus is more, as you all know, masking of tinnitus, that is the external sound. If the external environment is very calm, the patient will hear more tinnitus. Whereas if the external environment is louder than the tinnitus, then the patient will not feel the tinnitus. So that is called masking of tinnitus. Tinnitus is more annoying at bedtime, at the night time when the surroundings are quiet. So use of fan, loudly clicking clock or a similar device may mask the tinnitus and help the patient to go to sleep. So you need to increase the sound or the disturbances in the environment to make your tinnitus not feeling or not hearing you. Okay, so this is the masking of tinnitus. And this is a tinnitus instrument. It is a combination of hearing aid and the masker in one device. Okay, this is using of hearing aid and masker in one, both combined in one device. Okay, it looks like a hearing aid. Both hearing aid and masking device have independent volume controls, so you can adjust this volume controls and you can decrease the tinnitus, the ringing sensation in the ear. And the other one is the tinnitus retraining therapy, TRT. It's, if you rarely you can get this as a 2-mark question. And therapy, this tinnitus retraining therapy consists of two major components. One is counseling and the second one is sound therapy. In counseling, it is important to educate the patient about tinnitus, its mechanism of generation, how it is generated and how it is perceived, and the central nervous system reliability and perception of tinnitus at subcortical and cortical levels, and the plasticity of brain which can habituate any sensory stimuli. So you need to counsel the patient regarding the pathology of the tinnitus, how it is getting started, how it is being generated, and how you need to live with it. And the limbic system, the emotions and autonomic nervous system, body reactions are the primary sources of negative reactions to tinnitus. That is, sleep disturbances, inability to concentrate, annoyance, anxiety and depression are not the tinnitus per se. And the second one, the first one is counseling, the second one being the sound therapy, okay, in tinnitus retraining treatment. The patient is exposed to environmental sounds like music, radio, television, or using of hearing aids. Okay, so if the patient is allowed to expose it to environmental sounds, then the tinnitus levels can be decreased. Like he can perceive lesser tinnitus, and in general he should avoid silent environment. To produce external sounds for habituation, sound generators are used which produce continuous low level broadband noise for at least 8 hours a day. Therefore, sound here is used not for masking the tinnitus but is adjusted to remain at a low level for habituation. Here it is sound is produced or given for him for at least 8 hours a day, and it causes a habituation. Okay, it is not for masking the tinnitus. And tinnitus retraining therapy needs a long period of 18 to 24 months but gives a significant improvement in more than 80% of patients. So this is about tinnitus. Okay, the second topic for you for today is vertigo. So what is this vertigo? It is a sensation of spinning. Okay, it is a sensation of spinning where you feel like you are spinning or that the environment around you is spinning. Okay, so sensation of spinning around the environment, or sometimes you feel that you are spinning around the environment, or sometimes you feel that the environment is spinning around you. That sensation of spinning is called vertigo. So these disorders of vestibular system causes vertigo. Okay, so what is this vestibular system? Your inner ear has cochlea, utricle, saccule and semicircular canals. So these utricle, saccule and semicircular canals are, and along with your eighth cranial nerve, that constitute your vestibular system. Okay, and when there is problem in this vestibular system, vertigo is caused. So as you this vertigo is divided into two causes. Okay, one is peripheral causes and one is the central causes. So vertigo is caused when there are problem in the peripheral nerve region. That is, this peripheral regions involves the vestibular end organs and their first order neurons. That is the vestibular nerve. The cause lies in the inner ear or the eighth nerve. Okay, the problem cause can be in the utricle, saccule, semicircular canals, or sometimes in the eighth nerve, eighth cranial nerve, that is the vestibulocochlear. And these are responsible for 85% of all cases of vertigo. So mostly when a patient is coming to the clinical OPD for examination or evaluation, mostly you have to rule out the peripheral causes, because peripheral causes are responsible for 85% of all cases of vertigo. And secondly, the central causes of vertigo, which involves the central nervous system other than this eighth cranial nerve. Okay, after the entrance of vestibular nerve in the brain stem and involve vestibulo-ocular or vestibulospinal and other central nervous system pathway. As you all know, this vertigo is caused due to problem along the vestibular system. Okay, so peripherally, as you have just seen, and central, if the patient is having problem in the vestibular nerve after the entrance of the vestibular nerve in the brainstem, and which involve, there are various pathways which control your balance in your body. That is vestibulo-ocular reflexes, vestibulospinal reflexes and the other central nervous system pathways. So when there is problem in these pathways, the patient can have vertigo, that is central vertigo. And this is the etiology causes of vertigo. So what are the causes for peripheral vertigo and what are the causes for central vertigo? So peripheral vertigo, these are the problems which occur in the ear, in the inner ear or the vestibulocochlear nerve. So what are the problems in the ear which can cause vertigo? Meniere's disease, benign paroxysmal positional vertigo, vestibular neuronitis, labyrinthitis, vestibulotoxic drugs or ototoxic drugs, or head trauma, perineal fistula, syphilis and acoustic neuroma. These are the disorders, peripheral vestibular disorders which cause vertigo. And the other one being central lesions. What are the central lesions which can cause vertigo? Vertebrobasilar insufficiency, posterior inferior cerebellar artery syndrome, basilar migraine, cerebellar diseases, multiple sclerosis, tumors of brainstem and fourth ventricle, epilepsy and cervical vertigo. These are the central causes of vertigo. And what are the other causes of vertigo? Ocular vertigo. So this is a normally balance is maintained by the integrated information received from the eyes. Okay, eyes, labyrinth and somatosensory system. A mismatch of information from any of these organs causes vertigo, and in this case from the eyes. Okay, so ocular vertigo is the cause will be from the eyes. Ocular vertigo may occur in case of acute extraocular muscle paralysis or high errors of refraction. So when there is a problem in the eye, like this extraocular muscle paralysis acute condition, or if there are any high errors of refraction, the patient can have this ocular vertigo. And the other one is psychogenic vertigo. Like previously we have learned about psychogenic tinnitus. This also is similar, psychogenic vertigo. This diagnosis is suspected in patients suffering from emotional tension and anxiety. So when the patient is having some emotional tension or any anxiety, he can have this psychogenic vertigo. Often other symptoms of neurosis like palpitations, breathlessness, fatigability, insomnia, profuse sweating and tremors are also present along with this vertigo. And symptoms of vertigo is often vague in the form of floating or swimming sensation or lightheadedness. There is no nystagmus or hearing loss. Okay, caloric test shows an exaggerated response. So this psychogenic vertigo. So these are the causes of vertigo. Okay, peripheral causes, central causes, ocular causes, and psychogenic vertigo. There is another important. So as you all know, in this in the previous slide we have seen this vestibular disorders, the peripheral vestibular disorders causing vertigo. The second one being the benign paroxysmal position vertigo. This is very important. This you can get as a short essay. BPPV. Okay, you can get a question as BPPV or benign paroxysmal positional vertigo. So what is this BPPV? It is characterized by vertigo when the head is placed in the certain critical position. So when the head is placed in only in certain positions, the patient can have this vertigo. There is no hearing loss and any other neurological symptom in this BPPV. Positional testing establishes the diagnosis and helps to differentiate it from positional vertigo of central origin. So this BPPV, the patient is having peripheral vertigo. Okay. So this positioning testing establishes the diagnosis and it helps to differentiate it from positional vertigo of central origin. And disease is caused by the disorder of posterior semicircular canal. So as you all know, in the ear there are three semicircular canals: anterior, posterior and horizontal. So this disease is caused by disorder in the posterior semicircular canal. This is very important multiple choice question for you. They will give in BPP which semicircular canal is involved. So your answer is posterior semicircular canal. And though many patients have a history of heteromandial infection, it has been demonstrated that otocorneal debris consisting of crystals of calcium carbonate is released from the degenerating macula of the utricle and floats freely in the endolymph. Okay. So this is important. As you all know, the inner ear, in the utricle saccule of the semicircular canals, there is this otocorneal debris, and this otocornea is made up of these crystals of calcium carbonate. So these crystals of calcium carbonate, these will be released from this macula, and this otocornea debris will be freely floating in the utricle and in the endolymph. That will cause this BPPV. So when this otocorneal debris it settles on the cupula of posterior semicircular canal in a certain critical head portions, it causes displacement of the cupula and causes vertigo. So when this otocornea settles on the cupula of posterior semicircular canal in certain head positions, it causes displacement of cupula and then it causes vertigo. This is the pathology or etiology behind the benign paroxysmal positional vertigo. The vertigo is fatigable on assuming the same position repeatedly due to dispersible of the otocornea, but can be induced again after a period of time. Thus, typical history and Halpeck maneuver establishes the diagnosis. And the treatment for this BPPV will be Epley's maneuver. There will be few maneuvers, and this treatment, Epley's maneuver, is the therapeutic. The treatment for BPPV, remember this, very important. Epley's maneuver is a treatment. Okay. So any vestibular disorders, when the patient is coming with vertigo, you need to assess the patient. You need to evaluate this vertigo. Why is this vertigo and where is this coming from? Okay, and what finally you have to come to a diagnosis where either it is a peripheral vertigo or either it is a central vertigo. So when a patient is coming, how do you evaluate this? So there are two tests. One is a clinical test and one is a laboratory test. So as soon as the patient with vertigo is coming to your OPD, first you do some test in your clinic, okay, where you are sitting. So that are clinical tests. And further, if you come to a diagnosis after this clinical test, very good. And if you are not able to come to a diagnosis even after doing some clinical test, you need to do some other laboratory test, okay. Or sometimes you can confirm the clinical test by doing some laboratory test, okay. So what are the clinical tests? We will go. So these are this. How do you assess vestibular assessment of vestibular function test can be a short essay for you. So what are the clinical tests of vestibular system? The first one being the spontaneous nystagmus. So what is nystagmus? Nystagmus is an important sign in the evaluation of vestibular system. Okay. So as you all know, vestibular system, okay, is having vestibulo-ocular reflex. One of the pathway for this vestibular system being vestibulo-ocular reflex. So when the patient eye is affected, you get this nystagmus. When this vestibulo-ocular reflex is gone, the patient will get some nystagmus. So what is this nystagmus? Definition being, nystagmus is defined as involuntary rhythmical oscillatory movement of eyes. Okay, involuntary rhythmical oscillatory movement of eye. It may be horizontal, vertical, or rotatory. So when your eyes are moving, those eyes movement can be horizontal, just right to left. It can be vertical, up and down, and sometimes it can be rotatory. So vestibular nystagmus has a slow and fast component, and by convention the direction of nystagmus is indicated by direction of the fast component. So when your eyes are moving, when these rhythmical oscillatory movements of eyes, if you observe, it will be having a direction of fast component and a slow component. So by convention, the direction of nystagmus you have to indicate by seeing the direction of the fast component. To which side the nystagmus is beating fast, the eye is moving fast, that is indicated as nystagmus. To elicit nystagmus, how do you do this nystagmus? The patient is seated in front of the examiner, or sometimes he can even lie in supine position in the straight flat in the bed. The examiner keeps his finger about 30 centimeters from the patient's eye in the central position and moves it to the right and left or up and down, but not moving at any time more than 30 degrees from the central position to avoid gauge nystagmus. Okay. So 30 centimeter is the limit, is the distance where the examiner should keep his finger, and he have to move the finger up and down or right and left. By doing like that, the patient, if you see observe after some time, the patient can have vertigo, nystagmus. Presence of spontaneous nystagmus always indicate an harmonic lesion. So vestibular nystagmus is called peripheral when it is due to lesion of labyrinth or 8th nerve, and central when lesion. So it is called peripheral when the vertigo is due to lesion of labyrinth or 8th nerve, and it is called central when the lesion is in central neural pathway. So another one here is a fistula test. The basis of this test is induced nystagmus by producing pressure changes in the external auditory canal, which are then transmitted to the labyrinth. So what you do, fistula test also is used to find out nystagmus. Okay. So when there is some fistula in between your inner ear, so the main organ for your balance is inner ear. So when you are having some problem, when you are having some fistula or abnormal opening to your inner ear, the patient can have nystagmus. Okay. So this basis of this test is induced nystagmus. You have to induce nystagmus by producing pressure changes in the external auditory canal. So this external canal, when you are producing pressure changes, that pressure will go into the middle ear, and from that middle ear it is transmitted to the labyrinth. So stimulation of labyrinth results in nystagmus, and thus after nystagmus the patient will get vertigo. The test is performed by applying intermittent pressure on the tragus. Just put your index finger over your tragus and apply intermittent pressure. So, or sometimes you can use your sinus speculum to produce intermittent pressure. So normally the test is negative, because normally the patient will not have any direct connection from your external auditory canal to inner ear, middle ear, or middle ear to inner ear. Normally the test is negative because the pressure changes in the external auditory canal cannot be transmitted to the labyrinth. Okay, it is only the vibrations, the sound vibrations, that can be transmitted, but the pressure is not transmitted. And when there is some problem, like when there is some fistula in the inner ear, when you are doing this intermittent pressure changing procedures, it can become positive. So it is positive when there is erosion of the horizontal semicircular canal. So remember that your horizontal semicircular canal is related to your laterally, it is related to the middle ear. Okay, so when there is erosion of the horizontal semicircular canal, as in certain disorders like cholesteatoma, or a surgically created window in the horizontal canal, or abnormal opening of the oval window like post-epidectomy, or the round window, this patient will have positive fistula test. A positive fistula test implies that there is some connection between the inner ear and the middle ear. So a positive fistula also implies that the labyrinth is still functioning. It is absent when labyrinth is dead. Okay. So this is one more. These are few MCQs questions about fistula test, multiple choice questions. A false negative fistula test is also seen when cholesteatoma covers the site of fistula and does not allow pressure changes to be transmitted. Actually, when there is cholesteatoma, there will be horizontal semicircular canal erosion. But sometimes what will happen, the fistula is present, whereas when this cholesteatoma covers the site of fistula, this fistula test will not become positive, so that you get a false negative fistula test. And the false positive fistula test is without a positive. If you do a fistula test and you get a positive fistula test, but in the presence of fistula, so this is seen in case of congenital syphilis, okay, and 25% of M.B.B.S disease, that is called M.B.B.S sign. In congenital syphilis, stapes pupillate is hypermobile. In M.B.B.S disease, it is due to fibrous bands connecting utricular macula to the stapes pupillate. Very important. Okay. So false negative fistula test is seen in cholesteatoma, and a false positive fistula test is seen in congenital syphilis and M.B.B.S disease. So after this nystagmus and fistula test, the third one being the rhomboid test. The patient is asked to stand with feet together and arms by the side with eyes first open and then closed. So with eyes open, patient can still compensate the imbalance, but with eyes closed, vestibular system is at more disadvantage. In peripheral vestibular lesions, the patient sways or swings to the side of the lesion. So when the patient is asked to stand with feet together and arms by the side, and first by the eyes open and then close, after he closes his eyes, what will happen? The patient sways or swings to the side of the lesion. Which side the patient is having problem, that side the patient sways. Okay. In central vestibular disorder, patients to instability. So if patient can perform this step without swaying, sharpened rhomboid test is performed. In this, the patient stand with one heel in front of toes and arms fold across the chest. Inability to perform the sharpened rhomboid test indicates vestibular impairment. The other one is gait. So what is this gait? You need to ask the patient to walk in a straight line. So the patient is asked to walk along the straight line to a fixed point, first with eyes open and then closed. In case of uncompensated lesion of peripheral vestibular system, with eyes closed, the patient deviated to the affected side. Okay, the patient can't be able to walk in a straight line. He deviates to the affected side in case of uncompensated lesions of peripheral vestibular system. The other clinical test being past pointing and falling. The past pointing, falling, and the slow component of the nystagmus are all in the same direction. If there is acute vestibular failure, say on the right side, nystagmus is to the left side, but the past pointing and falling will be towards the right. Okay, that is towards side of the slow component. And there is another maneuver called Dix-Hallpike maneuver. This test is particularly useful when patient complains of vertigo in certain head positions. Okay. It also helps in differentiating a peripheral from a central lesion. So how to do this Dix-Hallpike maneuver? Patient sits on a couch, examiner holds the patient head, turn it 45 degrees to the right and then places the patient in supine position so that his head hangs 30 degrees below the horizontal. Okay? And then the patient eyes are absorbed for nystagmus. The test is repeated with head turned to left and then again to the right head in hanging position. Okay? And 4 parameters of nystagmus are observed. Latency, duration, direction and fatigability are the 4 parameters of nystagmus which should be observed. In BPPV, like in benign paroxysmal position vertigo, nystagmus appear after a latent period of 2 to 20 seconds and lasts for less than a minute and is always in one direction, that is towards the ear, that is undermost. On repetition of the test, nystagmus may still be elicited but last for a shorter period. Okay? On subsequent repetition, it disappears altogether. That is nystagmus is fatigable. So these are the clinical tests, and the other being the laboratory test of vestibular functions. So what is this laboratory test? One is the caloric test. So what is the basis of this test is to induce nystagmus by thermal stimulation of the vestibular system. So what happens when your vestibular system is stimulated? So as you all know, human beings have a body temperature, okay, being it some 36 or 37 degrees Celsius. So what happens when this inner ear is stimulated by using some water other than the normal temperature? So if you take a water, for example, a 30 degree, like it's like a more colder water, cooler water than the body temperature, or more hot water than your body temperature, like more than 40 degrees. So when you induce this, if you want to stimulate your inner ear, you need to use some temperature, okay, or more temperature or lesser temperature into your external auditory canal, and that will stimulate your inner ear. So this basis of this caloric test is to induce nystagmus by thermal stimulation of vestibular system. The advantage of the test is each labyrinth can be tested separately. So how do you do this? Cobrac, it is used done with the help of modified Cobrac test. It is a quick office procedure. Patient is seated with head tilted 60 degrees backward to place horizontal canal in your vertical position. So the problem is in the horizontal canal. Okay. So what you need to do? You need to place this horizontal canal in the vertical position, and that you can do when your head is tilted 60 degrees backward. Okay. Ear is irrigated with ice water for 60 seconds. First with 5 ml, and if there is no response, then with 20 or 40 ml. Normally, nystagmus beating towards opposite ear will be seen with 5 ml of ice water. If response is seen with increased quantities of water between 5 and 40 ml, labyrinth is considered hypoactive. Okay, no response to 40 ml water indicates a dead labyrinth. Even if you are giving 40 ml of water, ice water, and still you are not getting any nystagmus, it indicates that your labyrinth is dead. The other one being the Fritz-Gerald-Halbach test. It is a bithermal caloric test. In this test, patient lies supine with head tilted 30 degrees forward so that horizontal canal is vertical. Okay. Ears are irrigated for 40 seconds alternatively with water at 30 degrees and 44 degrees. This is what we discussed. So 30 degrees and 44 degrees Celsius water is taken and ears are irrigated, and then the eyes are observed for appearance of nystagmus till its end point. Time taken from the start of irrigation to the end point of nystagmus is recorded and characterized on a calorigram. If no nystagmus is elicited from any ear, test is repeated with water at 20 degrees for 4 minutes before labeling the labyrinth, and a gap of 5 minutes should be allowed between two ears, and cold water induces nystagmus to opposite side and warm water to the same side. Okay. Depending on response to the caloric test, we can find canal paresis or dead labyrinth in direction preponderance, that is, nystagmus is more in one particular direction than in the other, or both canal paresis and directional preponderance. The other laboratory test being cold air caloric test. In this test is done where there is perforation of tympanic membrane, because irrigation with water in such cases with perforation is contraindicated. So the test employs Dundas grand tube, which is a coiled copper tube wrapped in cloth. The air in the tube is cooled by pouring ethyl chloride and then blown into the air. It is only a rough qualitative test. Okay. So they can ask you when there is a perforation test, perforation in the tympanic membrane. Other than doing this bithermal caloric test, what you want to do, that is cold air caloric test. Dundas grand tube is used for this. And the other one being the electronystagmography. This is a method of detecting and recording of nystagmus which is spontaneous, okay, or induced by caloric positional, rotational or optokinetic stimulus. The test depends on the presence of corneoretinal potentials which are recorded by placing electrodes at suitable places around the eyes. The test is also used to detect nystagmus, which is not seen with the naked eye. The other one is optokinetic test. Here the patient is asked to follow a series of vertical stripes on the drum, moving first from right to left and then from left to right. Normally it produces nystagmus with slow component in the direction of moving stripes and fast component in the opposite direction. So this test is useful to diagnose a central lesion. The other one being the rotation test. So here the patient is seated in a Baroness revolving chair with his head tilted 30 degrees forward and then rotated 10 turns in 20 seconds. The chair is stopped abruptly and nystagmus is observed. So here normally there is a nystagmus for 25 to 40 seconds. The test is useful as it can be performed in cases of congenital abnormalities where ear canal has failed to develop and it is not possible to perform the caloric test. So disadvantage of the test is that both the labyrinths are simultaneously stimulated during the rotation process and cannot be tested individually. The other one being the galvanic test. It is the only vestibular test which helps to differentiate an end organ lesion from that of vestibular lesion. Patient stands with his feet together, eyes closed and arms outstretched, and then a current of 1 milliampere is passed to 1 ear. Normally, person sways towards the side of anodal current. Body sway can be studied by a special platform. The last one being the posturography. It is a method to evaluate vestibular function by measuring postural stability and is based on the fact that maintenance of posture depends on three sensory inputs: visual, vestibular and somatosensory. It uses either a fixed or a moving platform. The visual cues can also be varied. The clinical application of posturography is still under investigation. So these are the laboratory test for assessment of vestibular system, and the other one is vestibular evoked myogenic potential. This is the recent advances. This is a test to study function of otolic organs, sacral and utricle. Normally their function is linear excitation. Okay, they can also be stimulated by loud sound or of air or bone conduction. Even tapping the head can stimulate them. Myogenic potentials can be picked up from either the sternocleidomastoid, cervical muscle or ocular muscles, the inferior oblique or superior oblique, and have respectively been called cervical wemp and ocular wemp. So vestibular evoked myogenic potential is used to evaluate this vertigo, assessment of vertigo. Okay, thank you.